Hey everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to the channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with our friends. Today, our guest is Dr. Brian Greer, and he will talk about his study, Flexion Directional Preference in a patient with low back pain, utilizing mechanical diagnosis and therapy, a case report. The study was published in February 2022 in the Journal of Orthopedic and Sports Physical Therapy. Dr. Greer is a physical therapist and holds a diploma in MDT. I hope you enjoy the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative company Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi Brian, welcome to PT Pro Talk. How are you today?
I'm great, Mariana. Thanks for having me on.
Awesome. So today I'm excited to talk about the paper you published. So before we jump right in the topic, just tell us a little bit about yourself, your career, your background, and how did you get where you are right now?
Sure. So I'm a physical therapist in Connecticut, and I graduated from Springfield College in 2016. Pretty much right off the bat knew that I wanted to pursue higher education in MDT, the McKenzie method. I was lucky to have a clinical rotation with Joe Maccio Jr. in Troy at Maccio Physical Therapy, where I was pretty heavily introduced to the Mckenzie method. And from that rotation on, I knew I wanted to pursue it. So got certified after I graduated and became a diplomat in 2019 and just opened a Mckenzie Certified clinic 1 year ago in April 2021.
That's awesome. So you were lucky to have that on your rotation and then just go straight to Mckenzie and became a diplomat. So that's awesome.
Yeah,
Very
it's
cool.
funny. Everybody has their origin story, at least in the Mckenzie world. And we all have, multiple mentors and people that got us into it one way. You hear many diplomats talk about that. Definitely very fortunate that I was introduced to it so early. I was able to take a couple courses as a student and, didn't want to look back from there. So very fortunate for Joe and all the other mentors along the way, doing my diplomacy in Austin with Chris Chase and Kim Green. Just can't say enough about the level of education that the Institute provides and everybody who holds that value of that level of education. It goes a long way.
Yeah. Absolutely. So let's talk a little bit about the paper that you published, the case report, Flexion Directional Preference in a patient with low back pain, utilizing mechanical diagnosis and therapy, a case report. So just tell us a little bit how that goes.
Yeah, so this was a case that myself and Joe Maccio and Julia Tranquillo, who I did my clinical rotation with, it was a patient that we saw while I was on my clinicals, and that kind of gives you some idea about sometimes how long it can take to publish any kind of research. This is a process for sure, being published a few years later. But anyway, this patient was interesting, and I think the biggest takeaway from the case is how not all derangements in the low back are so straightforward as a lot of people might think they are. It highlights a lot of different force alternatives in order to get to the patient's directional preference. So it's pretty cool. This patient had been a previous patient of Joe's a year prior to coming in this time around. We saw him just a couple hours after he hurt his back. He had central low back pain, and being a previous patient with lower back pain a year later, he was extension directional preference, very straightforward, reduced really well with extension and lying. And Joe had done a really nice job of educating the patient on his last visit that, what to do in case this comes back. And the patient had hurt his back that day. He thought, all right, I'm going to go back to doing my exercises, started feeling worse. He was even so well educated that he decided to start going the opposite way and doing flexion and sitting on his own, which is pretty impressive for a patient a year after. Usually we don't get so lucky to see that. So that's where I think education plays such a big role. So it's pretty cool. Unique situation where a patient came in and he told us that he had already tried doing 10 repetitions of flexion and sitting and actually had unlocked some forward bend range of motion. He was describing how he was blocked in his ability to bend forward, which is kind of a cardinal sign of somebody who might benefit from some flexion, and felt that he could bend forward easier after he did some repetitions of flexion and sitting on his own. And from there, he pretty much said, I better go check back into the clinic because I'm sure that we're onto something already here.
Yes. That's pretty cool that he was so conscious about his mobility and what to try. So I think that was very interesting. So as you said, education was a big factor in his case.
I think it says a lot about how much we value education, especially at the diploma level. And, for people who are certified in the method, if you've gone through that process, you know how important education is. And this is a perfect example of that, where having a patient who knows that the first line of defense is at least some movement of their own versus I got to take medication or I got to go seek some kind of passive treatment or I need to go to my doctor. If you're in a place where there's direct access at that time, it's a significant thing that the patient knew he could do some kind of movement on his own, but then contact the person who had previously helped him out with a simple approach.
Yes. And how was the patient presenting on that day?
Yeah, so he came in and there was central low back pain. There was really no lateral loss of movement, which told us something too. It at least gave us an indication that we could stay in that sagittal plane, and regardless, we'd be testing that first following the method. And really, since he had done some of that repetition of flexion and sitting, he was at about a moderate loss of flexion, also a moderate loss of extension. So it's interesting, if you're looking at a patient on their first visit and they've been there before a year earlier, I think it's easier for maybe a more novice clinician to think, oh, we're going to put this patient through the same routine that we did last time. And you might feel like you're making the patient comfortable by saying, we've done this before. Let's go back to doing some of those exercises. And in this case, it's just, using all the information at hand, given the patient's history. He came in earlier that day. He had performed a high velocity Olympic lift, a squat clean, which involved some high velocity lumbar extension. So knowing that he felt blocked in his ability to bend forward, there was definitely an influence to think that there was a flexion directional preference. And of course that had to be tested because we can't assume that, but that's how the patient came in and that's how we knew where we wanted to start.
And then I saw that you described that you also did some lumbar extension in prone sustain to kind of check what the impact that would have, right?
Yeah, so just given that information that we already had, sometimes you get blessed actually having a patient come in their history telling you some really vital information. Sometimes they tell you nothing or they're a poor historian and you got to figure all that out. But in this case, it's using all the information we had. The clear first thing to do was to confirm that he needed some type of flexion movement. And using that sustained extension in prone, just according to MDT, that gives us a really good indication of if they have a lumbar derangement with a flexion directional preference, if they get off the table and then they're blocked and can't bend forward or have a significant increase in their inability to bend forward that way. And That's exactly what happened, which just is more confirmation that we knew that there was some kind of flexion that needed to be done to reduce this derangement. But that's where I think the paper gets interesting, and this case got interesting, because we think about how straightforward lumbar derangements can be, especially if you've got this information. You say, okay, we know this about their inability to bend forward now, and we think that he's going to respond to some flexion. And, when we started to have the patient bend forward after that, his symptoms were worsening. And that's where if you think you're following the system and you say, okay, you get that like red light response. Once again, I think somebody who might not have as much experience or might be quick to abandon the system would move on to something else. But in this case, we knew how significant our previous findings were and didn't want to abandon flexion yet, and decided to do a force alternative, which I think is an important thing for any clinician to keep in mind. Is if you can be in the right direction, and we learn this on the courses, don't think about immediately changing direction. Think about changing something else about it, like the starting position, in which case we unloaded him and had him lay supine. And even then he was performing flexion in supine, and had end range pain producing and increasing. And before we decided, all right, maybe we should test extension, we just sustained the patient in a mid-range lumbar flexion in supine. And after that, repeated flexion in supine reduced the patient's symptoms. And that was a significant part of this, showing that, it's not only repeated movements, it's sustained positions. And sometimes you got to try a combination of both in order to find what the patient needs day one.
Yeah, so I think that's really interesting, because you start testing flexion in sitting and then it got worse. So someone here could think, okay, that's not flexion, he's not better. But even like before abandon, try supine, because, unloaded, see if that gets better, and then got worse. And then by that point, someone could think that is getting worse. That's not the direction. So I think it was pretty cool, the idea that you had of trying sustain mid-range flexion in supine. So in the paper, they have pictures of the position. So if you're not imagining how to do that, let's just take a look at the pictures. That it's really helps to have an idea. So I feel that was really helpful to just give another insight. If you get stuck in the progression, you don't know what to do, well, just flexion, because in extension, we do sustain in prone more frequent, more often. But that was different for me, that part of the sustain flexion in supine. So that was another thing that made me stop and think, well, you can do that in flexion as well. It's just not as common, and it doesn't come to our mind like right away. So I felt like that was a good insight of a different position to progress, and don't make you give up on the flexion too early.
Right. Yeah. And I think that's where I think a lot of clinicians will jump ship from that point where they see, okay, not only is flexion not working like we thought it would, but they're not responding to a repeated movement like we thought they would. And people get really comfortable with treating more simple derangements. And when they don't come across that, they might be quick to, start to use a different approach and just try to make the patient comfortable in an uncomfortable situation. But this system lends itself to allowing us as clinicians, if you have enough training in it, to let the system figure it out for you. All you have to do is not only follow the rules, but adapt to what you're seeing. And that's one of the things that Rob McKenzie used to say himself, is just fiddle about. And there's a lot of cases where you're not doing something that's so straightforward and seeing a natural progression. There's cases where you got to fiddle about and figure out something different that the patient needs, just based on how they're presenting. That's how we developed this method. That's how it's been progressed over time. And this is just another example of how to use a method and use it really to its entirety, rather than deciding that it's not working or the patient doesn't need a certain direction or a certain approach and abandoning it altogether.
Yeah, yes, absolutely. So then you tried the flexion sitting, it was worse. Flexion supine was worse. Sustained mid-range flexion is supine for 3 minutes, right? And then what happened after that?
Yeah, so after the patient was sustained like that, then all of a sudden he started to respond well to flexion and supine after that. And, after 20 repetitions of that, we saw a favorable response. And there was enough indication in that moment that we decided to do a flexion mobilization and just progress force. I think parts of that were, Joe Maccio understanding how the patient had responded in the past and knowing the type of things that the patient was exposed to throughout the day, being an athlete. I did mention that he had switched to a standing workstation, which plays into some significance about why he might have responded more to a flexion movement. If he had now more exposure to a extension position throughout the day versus sitting in a chair for work, it makes sense that we might have seen that switch. But regardless, we mobilized him into flexion and supine. There's pictures of that as well in the paper, and ultimately reduced the patient's pain. We got about 90% of the previously obstructed range of motion back on that first visit. And once again, all of that information is enough to say to the patient, this is what you need to do right now. This is going to make you better. We sent the patient home doing flexion and supine every 1 to 2 hours and followed it up with them 2 days later.
And then how the patient was 2 days later.
Yeah, so it was nice to see, once again, this patient understanding the system, successfully being treated in the past, us educating him on why it's important to do it so often and that we needed to check in with him soon after he started that. We always ask the question, if 0% was day one when you first came in here and 100% is completely back to normal, overall, how much better would you say you're feeling at this point? And the patient had a 60% perceived improvement at that point. So that's enough to confirm that a derangement was present, that what we were doing was the right thing for the patient to continue doing. But, in the clinic, we always want to make sure that we're not being complacent with that improvement. And if there's something more that can be done to further progress this case, then we're going to do it. So once again, we fiddled about on that second visit and found that we could progress force at that point. The patient's derangement had reduced to a point that he was able to progress to doing flexion and sitting, and it abolished the pain that the patient had at baseline in that day. And that determined that it was just a better movement for him to do between the next 2 visits, which I think says a lot too. It's, in this case, you think about just the individual, this active guy. He was a hockey player. He had a standing workstation. This was before COVID, so it's not like he was working from home, but in an office. Easier for him to perform flexion and sitting, and people don't always have the opportunity to get on the ground. He did a great job of it, but I think allowing us to progress to a movement that was not only easier to perform, but more effective was just a home run in that case.
Yeah. And then on the third visit, he was much better, right? He was able to play like a full game of hockey. I think he was like a hockey athlete.
Yeah. Yep. He was able to play a full game of hockey. He said minor discomfort during some transitional movements, which is a pretty typical sign for derangements as they perhaps transition from a sitting to standing position or vice versa. But basically at that visit, there was not enough evidence to say that we needed to do anything else after testing a couple things in the clinic that day. Enough change to say, all right, you just played a full game of hockey versus 2 visits ago, you were able to bend forward. There's no change in what we had him do at home.
Yeah.
And then by the time he came back for the 4th, there was enough change where the patient was basically pain-free, and there was enough enough change for us to say that we wanted to look at extension again in a way to determine if the derangement was still present. And this was an interesting situation where, in any case or in most situations, you do want to perform some recovery of function using the McKenzie system, making sure that we can safely move into the opposite direction than the patient's directional preference. Not have any fear avoidance of going the opposite way and just get, in this case, the spine moving both ways to keep a healthy joint. And this patient was able to perform extension, gave us a good indication that the derangement had abolished. And in this case, the patient's history had said that a year ago he had a lumbar derangement that responded to extension. Here he is with lumbar derangement that responds to flexion. We gave him both exercises as a prophylactic program moving forward so that if the patient does have either one of these situations come back, he knows what to do. And once again, heavy education on, if you feel these symptoms, if you're unable to bend forward, this is what you should probably do, versus if, let's say, you sat for a long time and you have pain getting out of the chair and you respond to extension and lying like you did the first time. Once again, it's a powerful thing for somebody to be able to recognize on their own what they need to do for their own symptoms in different situations.
Yeah. And then how was the outcome long term? Did you track that? How was that?
Yeah, so overall it was 100% perceived improvement at that fifth visit. We were able to basically check in with the patient at a follow-up after discharge. This was a month after his initial evaluation, 15 days after his last visit. Basically told us that he returned to all prior activity. He didn't feel limited. We told him to keep on doing 10 repetitions of those movements twice a day. And the patient was back to doing all those things and working without pain and exercising without pain as well.
Awesome. So I think that was very interesting that you sent him home, like doing both, and have to educate him about what it means and what to do in specific situations, because he had experience through the two different arrangements with two opposite forces to reduce the derangement. So I think that was very interesting, and it can be confusing, but with a lot of education, I feel like the patient would probably be okay to self-assess and self-treat in case he needs it.
Mm-hmm. Yeah, and it's what the patient gets used to every visit that they're coming in. If you're constantly checking in, it's a reassessment pretty much every time they're in to see how they're moving, what they've been feeling in between sessions. They come in expecting, okay, like what am I going to do next, versus I'm going into physical therapy and going through the same group of exercises that I did last time. If somebody comes in knowing exactly what they're going to do in a treatment session for the lower back, they're probably going to the wrong place, unless it's so straightforward that you're following a natural progression of, let's say, like reducing a extension responder, and they know that extension and lying just continues to get them better and better. For somebody who has a more complex case, being able to confidently go somewhere and know that they're going to help me figure out what I need to do in order to fix this is a powerful thing. And yeah, it's one of those situations where not everybody is so cut and dry. And if they're a flexion responder and they go home on their last visit with something different than what the textbook says that a flexion responder would do long term, it's just because of what that individual presents with and what their history is. And I think people appreciate that if you thoroughly explain it to them the right way and they understand why they have to do those things.
Yes, absolutely. And I was just looking at your learning points from the paper. I thought it was very interesting, like the So the summary, like we briefly talked about failure to exhaust all force alternatives and loading strategies, like we talked about in the beginning. So I think that was very interesting. Do you want to talk a little bit about these learning points?
Yeah, I think it just really summarizes what happened here, where in this case, it was a good message for anybody who practices MDT or is going through the process of becoming certified or becoming a diplomat, where it's not always so black and white with somebody who responds to one direction versus the other. You need to take into account all those things that you learn in the courses, and there's so many different options and force alternatives that you can explore. They're there for a reason. They come year after year through the courses and continue to show up as ways to reduce a derangement, and they're worth exploring because they're out there even if you don't use them as often. I think we all get comfortable with our go-to approach based on how many patients we see respond to certain mobilizations or loading strategies. But when somebody who's a little bit more outside of the box comes in, you got to think that way and give them what they need in this case. And I think it's just a point to be patient with your own approach and not get flustered. You know, we could have easily had this person who looks and moves and smells like a flexion responder day one, and they start getting worse when we're flexing them. It's like, what the heck is going on right now? This is not the script that I saw coming in. But just being patient and exploring that force alternative, using a sustained position. I think people forget about those for the non-traditional cases, but especially in somebody who is acute, there's a lot of situations where those sustained positions will work out better. There's plenty of cases where they might not respond like somebody who's had this pain for 6 months would, but there's also plenty of cases where they might respond just like that, which is kind of the cool and challenging thing about derangements, where they're so variable. You got to be variable in your treatment approach to match that. And the other big thing, I'd say, the message that I want this paper to give, it's kind of cool that it came out during a pandemic where now there's a lot more people using standing workstations, or, you know, not using any kind of workstation at all if they're working at home. If they're sitting on the couch on a laptop every day to do their work, or if they're standing at their kitchen table with 6 textbooks built up under their laptop, it's important to ask those questions and get that information from somebody. It's easy to look over that and, you know, ask somebody in their history what they do for work, find out that they, you know, do some type of computer work, but leave it at that and not understand whether they're sitting, standing, lying down, still in bed when they're taking calls. You know, there's a lot of different force alternatives that they're putting themselves through throughout the day. So having that information just gives you a better idea about what the patient might need. And then being able to test that out, knowing that background information that you have is a key here. So in a world where standing workstations are more common, I'd predict that we might start seeing more of these. And a lot of people will probably overlook them because we get so comfortable assuming that somebody with this acute lower back pain just needs extension. And unfortunately, I hope that's becoming less of a stigma of the McKenzie method, because as you and I both know, it's just so much more than that. But for the people who test out extension or test out a repeated movement, see that it doesn't work, and then move on to something that's just making the patient comfortable or using a modality, it's a shame when they miss ones like this. And if you trust the system, if you use the information that you have and you follow the method the way that it's supposed to be followed, then the answers are presented to you in the patient's response to the things that you're doing. So using those symptom responses is very underrated and can really give you all the information that you need.
Yes, I agree. And I think it's important to remember about the patient history and pay attention to the positions that the patient stays throughout the day, because that gives a lot of information. It helps you to decide that you're going to start testing first And also the sustained positions to help you differentiate the flexion extension. I think that was a good reminder as well, that sometimes we go do a lot of repetitive testing and forget about the sustained position. So I think that was another point that was good to talk about.
For sure. And I think it says a lot about just how much we might rely on those tests and how much weight we put on them, where just because you see something in a special test or you hear something in a history that would give you information as to one thing doesn't mean it's absolutely true. And, there's plenty of lumbar derangements with a flexion directional preference that if you look just at a McKenzie form on the front page and you look at their better worse section, they might look just like an extension responder. And it's easy to assume one of those things, regardless of how they're presenting, and just get it wrong and get flustered. So that's where the front and back page work together really well on those McKenzie forms if you use them right. And it's just, like you said, taking that information into account to figure out what it is that patient needs.
Yeah. And do you have anything else about the discussion that you want to talk about? I know we kind of skipped that part of the paper. I don't know if there is anything that you want to mention about the discussion that you think is interesting.
Yeah, we kept it pretty concise with that message, but we highlighted just a couple other things. I mean, going back to how common this is, or at least was at the time, and the study by Audrey Long about what direction these people typically move in, if it matters what exercise that they're doing. At that point, there's only 7% of people with that lower back pain responding to flexion. So it's definitely less common. And I'm sure anecdotally, we all see that in our clinics and the population of people who come in with lower back pain. It's not super common that we find that people are going to respond to some kind of flexion movement, but they're out there and we can't ignore them and just try to put the square peg into a round hole. And then the other thing is just that the significance, I think, about the training in MDT. We highlighted that there was a study that looked at the level of education that somebody has in the McKenzie method and found that fewer therapy sessions were required for the patient when the treatment was performed by a clinician with the McKenzie education level of Part C or greater. So just more evidence that following the system the right way is ultimately what can really help to get these patients better faster. I think there's a lot of different ways to go about treating, and I think following a system is very useful, even if it's not MDT. But being able to know that system thoroughly to the point where you can use it effortlessly and just allow the system to figure out the patient for you is really underrated and something that should be utilized by people who are interested in whatever system that they're progressing.
Yes, absolutely. So transitioning to our final questions, if you don't have anything else to add about the study.
Sure. Yeah. Sounds good.
So what would be your favorite resource of information? Is there anything in particular that you like?
Yeah, so the McKenzie Institute does a good job of highlighting what's currently in the research. If you go onto the McKenzie Institute's website, you can find these references. I think that to some degree as diplomats, we have a nice system of being able to share with people from our class. At least I could say that about some of the people who I went through the diploma program with, just every once in a while getting a group text, hey, did you guys see this one? So that's where if you have your network of people that have a like-minded approach to you and you're together just trying to do a better job of it, it's fun to see what else comes out. But yeah, just going through the journals that come out and just trying to see what's out there. Again, the McKenzie Institute does a nice job of highlighting that.
Awesome. And in your opinion, what would be a good advice to clinicians that are starting their careers?
I'd say just finding that area that you're passionate in. I was very lucky to be exposed to it at a very early point in my career. And I think that even without that exposure, just seeing what you really resonate with and seeing what satisfies you when you're treating, as far as like what you see good results with, it's a nice way to find out not only how you want to spend your day to day, because it's very easy to just fall into a comfortable pattern of I'm going to treat patients and punch the clock. But, in this field, when you're utilizing a system that you are passionate about, it makes such a big difference. So just explore other options, take courses. You hear these stories from some of these other diplomats and people on the faculty who, just early in their career weren't satisfied with what was going on day by day and took a course, and 40 years later, here they are teaching them. So I think if you put yourself out there, it can go a long way, and don't be afraid to really pursue it. It's rewarding to get as far into a level of education as you feel like you can, and put the effort in early, because in a lot of cases it only gets harder to accomplish that the further you get out of school.
Yeah, and that's usually how their story goes. Like when you talk to them, the faculty diplomats, most of them were frustrated with their results, and they end up finding Mckenzie, and that's how they got really passionate about it. So
and they say, I wish I did it 10 years earlier, or however many years, fill in the blank. And it's of course it's easy to say things in hindsight that whatever it was that you were exposed to at the beginning in a lot of cases led you to the point that you're at in your career. So just taking it all as it comes and being able to pursue something that you feel passionate about goes a really long way.
Yeah. And what personal qualities and abilities that you think are important to become a successful professional?
That's a really good question. I think it comes back to that passion once again. I think if you're not passionate about what you're doing, it's easy for it to turn into a job. And you have to be curious enough to see what's out there and put yourself out there. But I think you also have to have an open mind and not be so dogmatic about what you do fall in love using. I think I can say for myself too, being exposed at such an early point in my career to MDT, it was easy to think, this is the only way to do it. And for myself, I knew it's the way that I wanted to treat, and it's a system that I wanted to use. But it's important to explore those other systems and understand what that looks like and what's the research on it, because, you're going to work alongside people who use those systems. You are going to come across those patients who, you're using the system that you do, you figure out what they need, and it might be an intervention that you're not capable of doing, or there might be interventions that are better than what you have to offer. And even in the Mckenzie system, we classify patients, and we don't just treat them with Mckenzie exercises. There's really no such thing. I think it's a case of classifying them appropriately and then understanding, does this person need sustained positions? Do they need repeated movements? Do they need an injection, or do they need a referral to, a psych consult? I think there's a lot of value in understanding what else is out there, because what you're doing is not always going to be the answer of what's going on inside your four walls. So yeah, putting yourself out there and being open to change is important, an important quality to have as you're going through your career.
Yeah. And I think that's a big thing, being able to recognize that you're not going to be able to help that patient refer as soon as possible and be efficient, and you're still helping the patient by referring him to or her to the appropriate professional that's going to be able to help them. So I think that's a big thing that I feel like the system also teaches us.
Absolutely. That's really my favorite part about using this system is, I think back to the patients that I treated in my first job before I had this level of education, and just how many people I tried to get better because I was excited about, having the ability to do that. But if I had been able to classify them the way that I am now, I would have saved some people a lot more time and given them the intervention that they needed earlier, even if it wasn't something that I could do. So yeah, I think that's where this system is awesome. And it allows us to be humble enough to say, this isn't the right thing for you and you need to go somewhere else. And that's the other thing, is expand your network and do your networking so that you know who the good people are in your area. And you don't want to be sitting in front of a patient Google searching neurosurgeons and not being able to confidently send them to somebody who you can say, this person's going to give you the time of day. If you need an injection, they'll give you an injection. If you need surgery, they're going to talk to you about that. And if you send somebody to a professional who just wants to push a service that they don't need, people can pick that up pretty easily. So expand your network of like-minded people.
Yes, absolutely. So Brian, if other PTs want to learn more about you, your work, or just contact you, how they can find you?
Yeah, so be happy to offer my email. I think I'm always excited to talk about this stuff. Send me an email, brian.greer@ptsmc.com. And always happy to jump on the phone, find a way to connect and see if people who are interested in doing this kind of stuff, there's a lot of resources out there that I can point them in the right direction.
Perfect. Well, thank you so much for taking the time and being here to discuss your study with us. I think it was really interesting to have like a Flexion one to discuss, because everybody just says Mckenzie is just extension. So I think it's important that we talk about the ones that are not as common, but still happen, and you still need to know how to progress, how to treat, and show that Mckenzie is not just one thing. So I appreciate you taking the time.
Absolutely. It was fun. Thank you, Mariana.